Today we are honored by the presence of Dr. Ban and Dr. Tonegawa from Keio University. So I'll just try to say some few words in Japanese. I'm sorry. 皆様こんばんは。私の名前は増若菜です。サンパウロ臨氷大学眼科のレジデント2年生です。本日は特別に慶応外科大学のバン先生と利根川先生にご参加いただいています。日本からお越しいただいて、私たちの親切にお迎えできることを大変嬉しく思います。So I will continue in English. No, my Japanese is not good. So that's it, and I will continue in English. So tonight I will present the case of Ocular Oncology Department. I would like to thank my supervisor, Dr. Ana Marisa Pires, and the chief of the division, Dr. Luis Fernando Teixeira. So the case is about a 65-year-old black man. He had a 5-year history of conjunctival lesion in the right eye with progressive enlargement in the past 3 months, and he denied any ocular pain or other symptoms. And he was hospitalized in March 2025 for wasting syndrome, oral candidiasis, and latent syphilis. And during his hospitalization, the patient was diagnosed with HIV, which his CD4 count was less than 200 cells by millimeters. His current medications were antiretroviral therapy, and he was initiated on March 2025. He denied any family history of systemic or ocular diseases. So his ophthalmological exam, he had a best corrective visual acuity in the right eye of 20/20 and 20/20 in the left eye as well. His intraocular pressure was 11 millimeters of mercury in the right eye and 9 millimeters of mercury in the left eye. The slit lamp exam, I will show some photos. And his fundoscopy exam, he had a pink optic disc with well-defined margins, with physiological cupping, normal vessels, and macula, and the retina is attached in both eyes. So here is the slit lamp exam of the right eye. So we can see that normal eyelashes and eyelids, arculus senilis, trophic iris, and the presence of irregular defined conjunctival lesion, dark in brown in color, slightly elevated and located in a temporal perilimbal region, 360 degrees, and the conjunctival pigmentation around the limbus, with pigment deposition near the carunculum and deep anterior chamber, and the patient is phakic. So here we have a closer look of the lesion of the right eye. And here the slit lamp exam of the left eye, we can see a normal eyelashes and eyelids, arcus senilis, bilateral 300 degrees, conjunctival ratios melanosis, trophic iris, deep anterior chamber, and the patient is phakic. So for the diagnosis hypothesis for this case, so consider a brown conjunctival lesion in an HIV-positive patient. The main diagnosis hypotheses include conjunctival melanotic lesions such as nevus, primary adichroid melanosis, conjunctival melanoma, and oration melanosis. Other differential diagnoses include pigmented squamous intraepithelial lesions within the ocular surface, scamal neoplasia, that is the OSN spectrum, such as pigmented actinic keratosis and pigmented squamous intraepithelial lesions. And also, degenerative lesions related to chronic solar exposure should be also considered. So for the management of this case, we request ultrasound by microscopy to assess the extent of the lesion and to evaluate the possible scleral involvement and give the presence of the hyperpigmented lesion in an HIV-positive patient with a severe immunosuppression. So here we have the UBM images. There are some artifacts that we can see over here, so we are just a little bit sorry about that. But it's possible to notice a slightly elevated brown lesion with a peripheral cornea to the bulbar conjunctiva with an extensive basal diameter. And the UBM was indicated in this case to assess the potential scleral involvement and to guide the treatment planning. So as UBM showed no evidence of scleral involvement, so the no-touch excision technique with saved margins was performed, And a dark lesion was completely excised and sent to histopathological analysis in this HIV-positive patient. So adjunctive cryotherapy was applied to the surgical margins to reduce the risk of recurrence and ensure the destruction of any residual malignant cells. Oops. This is only a schematic illustration show the lesion excision area with a 3 mm margin in red and the blue line representing the cryotherapy area. And also the absolute alcohol was used to facilitate the epilectomy. So the no-touch technique is a well-established oncology approach for the excisional biopsy of the conjunctival lesion, particularly those with malignant or premalignant potential. And its the main principle is avoiding direct manipulation of the tumor, which helps to reduce the risk of tumor cells dissemination and local recurrence. So surgically, the lesion is removed in block with adequate saved margins, and the tumor is handled only through the surrounding healthy area of conjunctiva. And this surgery allows the safe excision while preserving proper orientation for histopathological evaluation. And the margins were oriented with surgical sutures to accurate the histopathological evaluation. So this is only an image showing the no-touch technique for those kinds of lesions. So 1 month after surgery, no signs of lesion recurrence were observed, and we can see the good wound healing was noted. And here, just a closer look of the lesion. And similar findings were noted at 2 months post-operatively with no evidence of recurrences or having a good healing. So this image shows the histopathological slides demonstrating the cells ulcerations of the lesions. And here we have the epithelial disorganization involved the lower third with melanin deposition and scary dyskeratosis cells. The stroma shows changes consistent with solar elastosis. And a higher magnification, the basal epithelial layer shows marked architecture disorganization with significant cytologic atypia, including enlarged cell, irregular nuclear contours, and pleomorphism. And here, just a closer look to dyskeratosis and solar elastosis. And there's a epithelial disorganization with atypical cells in the basal third associated with a melanin deposition. So the histopathological examination revealed pigmented actinic keratosis, a premalignant lesion associated with ultraviolet radiation exposure, characterized by an acanthotic epithelium with hyperkeratosis and parakeratosis, and also a pigmented low-grade squamous intraepithelial neoplasia lesion without evidence of invasive disease and free margins. So here we're just going to talk a little bit the most prevalent ocular tumors in HIV-positive patients. So we have the ocular surface squamous neoplasia, that is the OCCN, which is the most common tumor. Is the most prevalent ocular tumor in HIV patients, is strongly associated with immunosuppression and occurs at a younger age and behaves more aggressively in those patients. Often involves the conjunctiva and the cornea, is a high recurrence rates compared to immunocompetent patients. So here we have a photo just showing what it's like. And also we just have to say of the Kaposi sarcoma, which is it is defined malignancy, which is caused by 8HV8, and is common, affects the eyelids, the conjunctiva, and the rare, but can occur in the orbit, and appears as this kind of lesion of red-purple vascular lesion, but the incidence decreased with the antiviral therapy, but is still relevant, and we still have to pay attention on these patients. And also, we're going to talk about a little bit about conjunctival lymphoma, which is usually non-Hodgkin B cells lymphoma, and may be present as a salmon-colored conjunctival mass, as the picture shows, and associated with a systemic lymphoma, and is more frequent in advanced immunosuppression. And here we have a picture showing what it's like. So for the final remarks for this case, we have to remember that HIV patients develop ocular tumors at a younger age. Tumors tend to be more aggressive and recurrent. And as I said, the OSN is more frequent and clinically significant. And the early diagnosis and oncologic surgery techniques, as the non-touch technique, as we explained today, are essential. And long-term follow-up is mandatory in HIV positive patients with conjunctival lesions due to the high recurrences rates. So, arigatou gozaimashita.
I want to invite Dr. Ana Marisa to talk about this case and add some comments.
Good evening. So congratulations, Wakana, for your presentation. We brought this case to emphasize some points. I think the first one is about the conjunctival pigmented lesions. When we see a lesion like that, we tend to think about nevi, melanoma, PEM, but it's important to remember the ischemial neoplasia. They can also be pigmented, and especially in individuals with some high level of melanin in skin. And the second point is about immunosuppression context. So when we have a patient like this one with HIV, we have to think about this ischemic neoplasia, even in pigmented lesions, because of the frequency of these lesions in this patient. And it's important to do a closer follow-up because they have a high risk of local recurrence. And it's important also to, when we see a lesion in a young patient with a growth, it's rapid, the rapid growth, actually, we must do a systemic workout to rule out any kind of systemic immunosuppression also. And at least it's about the surgical approach. So when we have a conjunctival lesion that we suspect that it has a malignant component, we have to do this gold standard technique that is what Wakana explained, that is the no-touch technique, and associated with the cryotherapy to try to minimize the risk of local recurrence, especially in immunosuppressed patients. So I think these are the key points of the presentation here. I don't know if Dr. Luis wants to do some comment. Any question?
I do. I'd like to know, what is the information you got from ultrasound biomicroscopy?
It's about the scleral involvement.
Okay.
Yeah, to know if the lesion was just superficial or more deeper than.
Excellent. Dr. Teixeira is not
Yes, he's here.
here. Comments?
He has no comments. Thank you.
Okay.
Thank you.
Great. Thank you.
Thank you, Dr. Ana Marisa. And let's invite Dr. Christian to present the next case.
Good evening, everyone. My name is Christian Nogueira. I'm a second-year resident here at the service. I present the retina case of the night. And my advisor was Dr. Frederico Novaes. I would like to give special thanks to Dr. Clara Castro, who helped me with the case. The head of the division was Dr. Caio Regacciani. The case is about a 33-years-old female patient from São Paulo who had sudden and painless low visual acuity in the right eye for 3 days. No trauma history. At medical past, she had a pulmonary tuberculosis 3 years ago that was properly treated with no sequela, and her ophthalmologic past was remarkable. At ophthalmological examination, she had a best corrected visual acuity of 20/50 in the right eye and 20/10 in the left eye. For anterior biomicroscopy of the right eye, I will show you photos. In the left eye, she had normal eyelids and eyelashes, clear conjunctiva, clear cornea. Anterior chamber was formed and the patient was phakic. Intraocular pressure was 18 and 16, and I will show fundoscopy photos of both eyes. Anterior biomicroscopy of the right eye, we had normal eyelids and eyelashes, a clear conjunctiva, clear cornea. Anterior chamber was formed and the patient was phakic. Retinography of the right eye, we have a pink optic disc with sharp margins, cup to disc ratio of 0.4, periretinal microhemorrhages inferior temporally, and fibrotic lesion extending superiorly, and we can see also ghost cells temporally. Retina is attached, as we can see. Wide angle showing no other alterations in superior and inferior nasal sectors. And at nasal periphery, we had a vascular proliferation with no hemorrhage. In the left eye, we had a pink optic disc with sharp margins, a curve to disc ratio of 0.2, periretinal hemorrhage at temporal periphery. It might be salmon patch pattern, but we can see now a periretinal hemorrhage, and vascular proliferations inferior to the lesion. Retina is attached and macula is normal. For diagnostic hypothesis, we have a young female patient with no ophthalmologic history, with a peripheral and bilateral periretinal hemorrhage, and what seems like a neovascularization. We have to consider vascular causes as branch vein occlusion, sickle cell retinopathy, hyperviscosity syndrome. We also have to consider infectious causes as syphilis, tuberculosis, and inflammatory etiologies like vasculitis or sarcoidosis, for example, or Ehrlich's disease. For the initial management of the case, we order optical coherence tomography and fluorescein angiography, and laboratory tests to rule out infectious and inflammatory diseases like blood count, rheumatoid factors, syphilis, and HIV, and tuberculosis serology. And we also ordered hemoglobin electrophoresis to assess hemoglobinopathy-related occlusions. In the OCT of the right eye, we had a vitreoretinal interface that was normal, foveal depression preserved, but with temporal retina thinning and external disorganization of outer retinal layers. And we also had a fibrovascular proliferation and disorganization of the outer layers in the inferior temporal region, where we had the hemorrhages. The OCT of the left eye, we have a vitreoretinal interface without alterations, a preserved foveal depression, and a good parallelism of retinal layers. She had no complaints in this left eye. Here in the area of hemorrhage, we had a thickened hyalid membrane with hematic impregnation without traction in the inner retinal layers. Here we have the autofluorescences of the right eye, and we can see hypoautofluorescences by block inferior and temporally to the macula. Acho que é a internet agora. Sinal aqui tá. Não. Mas enquanto eu estava falando também, não estava passando. Tava. agora foi. Here in the autofluorescence of the right eye, we have areas of hypoautofluorescence by block inferior and temporary to the macula. And the angiofluorescence in the right eye, we have hyperfluorescence in inferotemporal with progression, extension, intensity in a pattern of leakage associated with hypofluorescence due to filling defect temporary to the macula. We also had a local hyperfluorescence at nasal periphery. And the autofluorescence of the left eye, we have hypoautofluorescence by block, also in the temporal periphery. And in the angiography, hyperfluorescence in inferotemporal with progression, extension, intensity in a pattern of leakage, as in the other eye. Temporal and in inferonasally, we also had hypofluorescence due to filling defect. And at superior periphery, we also had leakage in the left eye. And the complementary exams and the blood count, the glycated hemoglobin was normal. Serologies for HIV, syphilis, and tuberculosis were no reagent. The inflammatory tests were normal too. But the hemoglobin electrophoresis showed a predominance of C and S hemoglobin, characterizing SC hemoglobinopathy. And the diagnostic hypothesis for the case was sickle cell proliferative retinopathy associated with SC hemoglobinopathy. And for the management, we performed the photocoagulation guided by the AGF in both eyes. And the retinography of the right eye, we can see that it was performed photocoagulation in ischemic quadrants and around the siphons, the neovascularizations that we saw. After 2 sessions of laser, most of the ischemic area was photocoagulated, although the leakage still remained. Here we have the wide view. That localized nasal lesion seemed to have regressed, but the inferotemporal, the larger one, remained with leakage. In the left eye, the angiofluorescence status after the photocoagulation, after 2 sessions of photocoagulation. It was almost a pan-retinal photocoagulation except for the inferior quadrant. The patient continues to be monitored at the outpatient clinic without new complaints, and we perform new exams to decide future management. And we brought this case for discussion because retinopathies associated with hemoglobinopathies are frequent and vary according to the genotype. HBSS is more associated with non-proliferative retinal alterations, while HBSC has a higher risk of proliferative sickle cell retinopathy. And the central event is vasoocclusion in peripheral retinal microcirculation, which causes stasis and thrombosis and leads to ischemia. Chronic ischemia leads to upregulation of angiogenic factors and produces peripheral neovascularization, which is called CFAN. Physiological triggers to vasoocclusion are hypoxia, acidosis, hyperosmolarity, and dehydration. And the practical implication of peripheral disease is that it can be silent until vitreous hemorrhage comes, so screening is recommended. There's a classification of proliferative disease that helps us to understand its progression. It's called Goldberg classification. First stage, there is a peripheral arterial occlusions. There are peripheral arterial occlusions that lead to atrophy and non-perfusion. At second stage, peripheral arteriovenous anastomosis is developed. And finally, at stage 3, CFAN L vessels appears and start to leakage at angiography. Then at stage 4, we can have vitreal hemorrhage, and in the last stage, there is retinal detachment that is typically tractional. Therefore, patients with sickle cell anemia should have at least annual screening, and proliferative form from stage 3 should be treated with photocoagulation. Laser reduce visual loss from 6.7 to 1%, and reduce the incidence of vitreous hemorrhage from 18 to 10%. Adult C-FAN closing rates are low. Recent studies had showed that anti-VEGF injections had good results in regressing new vessels, with recurrences of 33% in 1 year. For vitreous hemorrhage and tractional retinal detachment, pars-plana vitrectomy is well indicated, although retinal detachment recurrences is up to 50% higher than in non-sickle cell detachment. We brought this case report also of a 36-year-old black man with bilateral progressive visual loss who developed the tractional retinal detachment in both eyes secondary to proliferative sickle cell retinopathy. And she also had SC hemoglobinopathy. And despite few systemic symptoms, the patient had severe ophthalmologic manifestations, confirmed by examination, ocular ultrasound, and hemoglobin electrophoresis. For the case, the management was expected due to the low prognosis of the retina that was 7 years in suffering. That case illustrates that SC hemoglobinopathy, although less symptomatic systemically, is associated with a higher risk of visual loss. For take-home messages, we like to highlight that SC hemoglobinopathy may start through the retina. Peripheral vascularization, the C-FAN, may remain silent until vitreous hemorrhage happens. And the form of greatest risk is the proliferative. Visual loss comes from vitreous hemorrhage or tractional retinal detachment. And photocoagulation is a treatment for the proliferative form, and vitrectomy may be indicated in cases of persistent vitreous hemorrhage or retinal detachment. Thank you.
I'd like to invite Dr. Frederico, the advisor of the case.
So congratulations, Christian, very well presented. And we would like to highlight that it's not normal to have a neovascularization in the retina, especially in young patients. So you have to think about infectious disease. This patient had the history of tuberculosis. It was pulmonary tuberculosis and had no ocular symptoms, so it's important to think about this. And also inflammatory disease, such as Ewell's disease, but is a diagnosis of exclusion. And since the hemoglobin had an SC pattern, we have the diagnosis of sickle cell disease. That's it.
Fred and Christian, and something that I want to highlight to Dr. Bunny is I have a lot of tuberculosis here in Brazil, and also sickle cell anemia here. So when you see a patient like this with a previous diagnosis of tuberculosis, although it's not something that is characteristic, you have to think about tuberculosis. And one tip is on the OCT, when you have the thinning of the temporal retina, it's very common to see in patients with sickle cell anemia. So something that to remember.
Due to previous infections.
Just one comment. So actually, Japan is very unique country because the genetic background is, almost universal. So actually, I never seen the sickle cell anemia patient in Japan. When I was in New York City, I saw the patient, but in Japan, I never. So maybe residents see that, this kind of patient, they never know it's, sickle cell anemia. That's also, yeah.
Yes. Mm-hmm. So it was good to knock out to.
Boa noite, todos. Meu nome é Norimitsu Ban. Sou da Universidade de Keio. I'm sorry, from now, I'm going to speak in Japanese. Sorry, not Japanese, in English, okay? So hello, everyone. I'm Norimitsu Ban from Keio University. So I'm here to introduce not only the topic, recent topic on retina in Japan, but also I want to introduce our university to you. Actually, that's why I'm here, okay? So we agreed the exchange program between Keio and Unifesp. So I want you guys to come to Japan someday or very soon, okay? Okay, as Naoya mentioned, this is our university hospital. And next, please. So first of all, I would talk about a little bit about our university. So the Keio University is one of the very historical, prestigious university. It's founded 1858. Okay, he's a founder of Keio University, Yukichi Fukuzawa. He was a kind of pioneer Japanese educator, and he was a giant of this Meiji era. Next, please. And actually, there is another giant for the Keio University, the founder of School of Medicine. His name is Shibasaburo Kitasato. He's a bacteriologist, and he discovered the plague bacillus and the tetanus antitoxin therapy. So he was very famous. Okay. And there's a hall inside the Department of, the School of Medicine. Okay. By the way, this is my son, who is 18 years old. Next. And actually, next please. Okay, this is interesting. Yukichi Fukuzawa, Shibasaburo Kitasato, they are iconic for the Japanese bills. Especially for the Yukichi Fukuzawa, this is 10,000 yen bill. This is the most expensive bills in Japan. So that's why he's very famous, because everybody loves money, right? Okay, next please. Okay, so I will introduce our department, Keio University Department of Ophthalmology. This is our department. Next, please. So actually, I was surprised that your department has much bigger scale compared to ours. But actually, ours are relatively big in Japan. So our attending, like 16 attending, the cataract refractive, 3 attending. Retina has a lot of attending, including me, 6 attending. Glaucoma, 4. Cornea, a little bit weak. Orbital, neuro, uveitis. And we have 10 residents per year, and one of the residents is now here. Okay, next please. And coincidentally, we have exchange program between UIC, University of Illinois at Chicago, and I know that you also have the communication with them. Actually, our program is very historical because it's since 2007, okay? But it's suspended between the COVID pandemic, but we restarted from 2024, last year. So this is a picture from last year. So the 3 residents from UIC visited Keio, and of course our resident visited UIC. Okay, so yeah, it's good. Next, please. Okay, from now, this is the main topic of today's talk. So actually, I would just give you, two short topic. Okay, so one is the new instrument for the IOL scleral fixation, because as Naoya mentioned about the endophthalmitis cases, I will introduce some topic about the IOL fixation, okay? So this is the new instrument for the IOL scleral fixation, 31 gauge super thin wall needle, okay? So I think in double needle technique, or known as Yamane technique, do you do that, right? Here. So what gauge needle do you use? 27 gauge? 31? You have? Already? Wow. It's not a new topic? But by the way, that's fine. Yeah. Okay, go ahead. So this is the, as you know, the Yamane technique is very the famous technique right now. Okay, here we go. So the background, so the original technique raised by Yamane was they used the 30 gauge thin wall needle, okay? But it requires delicate technique. And of course, we can use the conventional 27 gauge needle, but it increased the invasiveness. Next, please. So we use the made in Japan 31 gauge ultra super thin wall needle this time, okay? So the left side is 30 gauge thin wall needle. The outer diameter is like this, and the inner diameter like this. So our 31 gauge needle has outer diameter is of course thinner, but inner diameter is more wider, okay? And as Dr. Hida mentioned, we use the NX70S lens by Santen or PN6AS by Kowa. Of course, I'm sorry, they are made in Japan. The haptics is 0.14 millimeter. Next, please. So this is the case 1, 73 years old male, and this is right eye, decreased visual acuity due to the IOL dislocation. The past ocular history, 10 years ago, he received the vitrectomy and phaco for the retinal detachment. And our plan is IOL scleral fixation and using the lens NX70 Santen. Next, please. Okay, this is the video. So we put the needle at the 3 o'clock and 9 o'clock, as usual. We insert the haptics into the needle. And again, the inner diameter is wider than the 30 gauge thin wall needle. It's more smooth. Okay, and again, cut the flange. Cut the haptics and make appropriate flange. Okay. Okay, next, please. And the result. So the fixation time from 31 gauge needle in and the final flange set was 7 minutes 30 seconds. And the visual acuity pre-operation and post-operation is like this. And no complications such as flange exposure or hypotony. And next, please. The next case, case 2, 75 years old male, decreased visual acuity, right eye due to the cataract. And actually, for this case, we did phaco for the cataract, but during the surgery, we realized, inferior general dialysis more than, 180 degrees. So we decided to do IOL scleral fixation using the lens NX70 Santen. Next, please. And another result, 31 gauge fixation time is 7 minutes, 34 seconds. And the visual acuity is like this, and no complications such as flange exposure or hypotony. Okay, next, please. So discussion again. This time we experienced two cases, 31 gauge needle, and the fixation time on 7 minutes and 30 seconds and 7 minutes 34 seconds. And it's less than previously reported at average 11.2 minutes, okay? And again, this is the stats for the 30 gauge needle and 31 gauge needle. So wide inner diameter makes the procedure easier. Next, please. So the conclusion. So we use the 31 gauge super thin needle for the IOL fixation and the small outer diameter and large inner diameter. Next, please. So increase the fixation strength, reduce the risk of flange, exposure, and endophthalmitis. And it also simplified the procedure. Okay. So the conclusion, the simple conclusion is the thinner, the better, okay? And actually, go back. So we just published this case report for the retinal case and brief report 2025. So if you're interested in, please refer this article and I have a souvenir for the retina fellows. Sorry. Please try, okay? That's gonna be good. Okay, next, please.
Just two questions.
Mhm.
Sorry, I think we use here is the 30 gauge needle.
30 gauge,
Yes.
that is the original method. Yeah,
Yes.
and Yamane used the 30 gauge
Yes.
thin wall. This is 31 gauge super thin wall. Yeah.
So we are going to try and make some videos and send you.
Okay.
And another question, what's the measurements that you use? Because I saw that you didn't measure, so you have made a lot of surgery, so you don't need to measure, right?
A measure means the
Between the limbus and the play.
we usually measure. So usually I prefer 2 millimeter, but some operator use the 2.5 millimeter.
So you
Yeah.
prefer two?
Yes.
Okay.
Yes, but cut the haptics. Okay.
Yes.
Yeah, because if we set the 2 millimeter from the limbus, and if do not cut the haptics, the case like Naoya mentioned, the haptics exposure could happen. Yes.
Thank you.
You're welcome. Okay, so next. Okay. Oh, by the way, coffee break. Oh, this is the picture. I played golf the other day. Please. This is me. Dr. Yamane. He's my friend. Yeah, I think Dr. Yamane is now, the most famous Japanese ophthalmologist. He's like this, smiling. Okay. Oh, okay, so here I'm gonna introduce myself, okay? So, same as Naoya, I graduated Keio University almost 20 years ago. Yes, 20 years ago. Yeah, and I did residency at Keio University in Tokyo and Yokohama. And actually, I did some, basics. Actually, a lot of help, I'm going to present, the basic science stuff. I'm sorry, it might be boring for the resident and fellow, but I did some, PhD. Oh, sorry. Oh. Yeah, I did my PhD training in the United States at Washington University, St. Louis. And then I moved to New York City to do a clinical surgical fellowship at the Columbia University in New York City. So I have 5 years study in the States, and then came back to Japan and got the faculty position at Keio University. Okay, so just the basic science work when I was at the Washington University. So he's my mentor, Dr. Legenda Apte, and this is, do you know what it is? This is actually not the human. Yes, the mouse retina, the fundus picture, and this is the mouse I made when I was in the States. So this is the kind of the AMD model. So this is, it looks like drusen, right? So of course, if you're interested in, it's already published in 2018. If you're interested in, please refer to my the paper, okay? Okay, and this is my surgical fellowship time. So maybe Dr. Kyle, Dr. Stanley Chan, right? And maybe young doctors does not know Dr. Stanley Chan right here, but he's a kind of the legend of retina field. Okay, so he invented PFCL, the peripheral carbon. So he used PFCL for the first time for the human clinical use. Okay, so actually he was my mentor at the time, and this is the OR at the Columbia University where I'm operating, okay? Okay, so this is the retina faculty at Keio. And actually, the operation room setting is almost the same. We use the constellation for the vitrectomy, and we have Ingenuity size microscope. But yeah, actually, the surgical volume is for sure, less than yours, but we are, doing good. Okay, so from now, maybe 10 minutes. Might be boring, but please listen to my the basic science stuff, okay? Consono? Now? Okay, this is the talk about the photoimmunotherapy for age-related macular degeneration. Oh, by the way, this is my laboratory for the basic science, and Naoya is also here. Yeah, so I have very, very good member for the basic science as well. Oh, okay, and it's already published. Last year, I published this stuff for the IOVS. So if you're interested in, please refer to the paper already published, okay? Oh, this is the picture from the IOVS paper. Okay, so I'd like to present a research on photoimmunotherapy for AMD. So let me begin with the purpose of this research. So this study aimed to develop a curative AMD treatment with fewer administration by combining VEGF receptor 2 and photoimmunotherapy. So first of all, the current AMD treatment can be categorized into the anti-VEGF therapy and photodynamic therapy, as you know. Anti-VEGF therapy has shown potential for vision improvement. However, it often does not completely regress CNV, therefore requires multiple administration, as you know. But the PDT only helps in maintaining vision, and it's associated with complications such as hemorrhage. To address this challenge, our study aimed to propose a novel treatment approach, namely photoimmunotherapy. The photoimmunotherapy utilizes a complex compromising monoclonal antibody and fluorophore IR700 that react to the near-infrared light. By binding the complex to the target cells and exposing them to near-infrared light, target cell-specific cell death is induced. This is a simple principle of photoimmunotherapy. Currently, the photoimmunotherapy is undergoing phase 3 clinical trial by FDA for neck and head cancer treatment. So in this study, we conducted the experiment aiming to apply photoimmunotherapy to the novel treatment of AMD. So first, we perform an in vitro assay using BN3 cells, which is derived from mouse vascular endothelial and known to be expressed VEGF receptor 2. The DC-101, which is VEGF receptor 2 and IR-700 was administered to the culture medium. And after 24 hours of antibody treatment, near-infrared light was irradiated, like this. As shown in orange bar in the graph, a laser intensity-dependent decrease in cell viability was observed in antibody-treated group. In contrast, no change was observed in the blue control group without antibody treatment, indicating that the efficacy of photoimmunotherapy in vitro. So next, we performed in vivo experiments using laser-induced CNV model mouse. So VEGF receptor 2 expression was observed in CNV from day 5 towards in this model. So at first, this model, we administered DC-101 Alexa 488 complex intraperitoneally on day 4 after CNV induction and confirmed the localization on day 5. The complex was localized within CNV lesion and co-locally with other VEGF receptor 2 antibody. The following the protocol, we introduced the DC-101 IR-700 complex into the CNV model mouse and performed photoimmunotherapy. As a result, the cell death was induced, indicated by tunnel-positive cell, and CNV was observed in 24 hours after photoimmunotherapy. Okay, so this is the final slide. Here's the result of CNV volume. The photoimmunotherapy group here, which received both antibody administration and near-infrared exposure, showed a significant reduction in CNV volume compared to the control group. Conversely, no significant change was observed in either antibody-only administered group or near-infrared only group. So this confirmed the reduction of the effect of CNV by photoimmunotherapy. So in conclusion, this study demonstrated that the localization of the DC-101 fluorophore complex within CNV and the induction of cell death by photoimmunotherapy. We showed a reduction in CNV volume with both photoimmunotherapy and the PDT photoimmunotherapy. Based on these findings, we believe that the photoimmunotherapy targeting VEGF receptor 2 could be the novel treatment for the AMD. So this is the acknowledgement. I'd like to express my gratitude to my collaborators and colleagues. And the most important message for you is we are here to welcome you and bem-vindo. And thank you so much. Muito obrigado.
Thank you for your talk, very nice talk. I also did my PhD in molecular biology, and I also have research projects in molecular biology, especially because my wife, she's a molecular biologist here at Unifesp. So I do a lot of work with angiogenesis too. And my question is, what is the wavelength that you are applying to applying these cells?
The cells?
And those cells. the what's the
B and 3 cells?
yes?
Mhm.
What's the wavelength that you are using?
It's an endothelial cell.
Ah, okay.
Yeah, mouse endothelial cell. Yeah, and which expressing vasoreceptor 2.
And are you now moving to human studies or?
Yes, actually, all retina doctors know, the PDT, photodynamic therapy, right? So this photoimmunotherapy is kind of similar treatment for the PDT. And actually, in our paper, we use the slit lamp, the PDT laser for the treatment. So that means, we can easily convert this, basic science stuff to
Yes.
the human stuff. Yeah, so we are trying to do that.
Great job.
Thank you
And
so much.
thanks
Muito
for-
obrigado.
Thanks for coming to our university, and for sure we are going to visit you in Japan.
De nada.
Gostaria de agradecer a presença de todos e vamos encerrar o nosso Grand Round. Boa noite. Doutora Norma, obrigada.